So if you've joined us today for the Children's Hospital Philadelphia Rett Clinic Town Hall, you're arrived at the right place. My name is Paige Nues. I'm Director of Family Empowerment at RettSyndrome.org. And all of us at RettSyndrome.org want to thank you for being with us today and for your support and engagement. We believe that information on our rare disorder should be free to all who avail themselves of it, and we thank you and all of our supporters for that shared belief. We especially wish to thank ACADIA Pharmaceuticals, Greenwich Biosciences, and Neuron Pharmaceuticals for supporting our education programs, which allows us to direct more fundraising and donor dollars to our research programs. So as we find ourselves at the crossroads of many issues competing for our attention and resources, we felt it was time to recenter and refocus our attention on this road that is most personal to us, that we were cast upon with our children, not because of anything we did or didn't do, but a difficult road that can be very lonely indeed if traveled alone and without help or hope. And we at RettSyndrome.org know that Rett syndrome knows no boundaries. It affects 1 in approximately 10,000 females worldwide, and even more rarely in males. Most have never heard of it, and none of us parents wished for it for our children. However, the bright and engaging smiles and eyes of our mostly nonverbal children do envelop our hearts and minds with purpose and move us to find strength we never thought possible. All of us at RettSyndrome.org, our board of directors, our virtual team across the US, and League of Parent Volunteers are committed in partnership to offering education, connection, and advocacy for all affected by Rett syndrome while investing in research progress. I say that both as your Director of Family Empowerment at RettSyndrome.org and as mother to a beautiful teenager with Rett syndrome. It's been our pleasure to partner with the entire team at CHOP for many years now for referrals, knowledge, compassionate clinical care, the natural history study, data collection efforts through clinical trials and working groups. And they know and they care. And we were so disappointed to have to move all of our in-person events and fundraisers online this year. However, as a testament to their commitment, fortitude, creativity, as well as ours, we have found this way to meet online virtually to bring you up to date with current events. We were able to meet in the Philadelphia area about 1.5 years for the in-person Ed Day, but I'm thrilled to see so many faces that were with us at that time. Thank you for joining us today. And I see many, many new families who weren't able to be with us on the Ed Day or perhaps weren't diagnosed at that time. And we are really grateful for you for joining us today to meet your team at CHOP, to learn a little bit about RettSyndrome.org and then what we've been up to over the summer. We did not go dark despite the 2020 disruptions. Everybody's support leading into 2020 enabled us to continue our work. And our team at CHOP continued some fantastic work, and they're here today to give you updates on clinical trials and clinical research, clinic appointments, and, whoops, sorry, phone's in the background. And to answer some of your questions. So it's with deep gratitude that we welcome Dr. Marsh. And Dr. Marsh, if you'd like to come on the screen here, I'll go ahead and turn slide share over to you. So we can hear a little bit about what's going on at your clinic. And then after your whole team, go ahead and bring your slides up. There you go. So as we go through Dr. Marsh, he's going to introduce his team, talk about the clinical research clinic structure at CHOP, as well as some of the clinical research programs.
Yeah, so I actually don't have a slide. I'm going to just echo everything Paige said and thank Paige and RSO for allowing us to reach out to the community and interact with the community in these trying times that we are now all in, and to make clear to everyone that we are still here, that we can arrange video visits, in-person visits, telephone visits, whatever's needed to help you all with the care of your children and adult children, and that we are still performing research, and the continued attainment of new knowledge and of new treatments is ongoing. And though COVID has slowed it down, we are still trying our best to move everything forward as fast as we can with the limitations that are put in front of us. So, with that, I'm gonna turn this over to the team here at CHOP. We do work as a team, and I want to thank Holly Dubs for organizing. And you're going to hear from Holly and Erin and Sam and Brian and a whole bunch of other people to tell you what's going on in our clinic. And with that, I'm going to hand this over to Erin. And again, thank everyone from our team for participating today. And thank you all for showing up and taking the time to spend some time with us today. So thank you, Erin, all yours.
Hi, good afternoon, everybody. As Dr. Marsh said, my name is Erin O'Connor-Prang. I'm one of the nurse practitioners in the Rett clinic at CHOP. And so I'm just going to speak to you a few minutes today about the options that we have here at CHOP. So our current Rett team is comprised of neurology, gastroenterology, and several therapists. We're not going to go through all these slides just for time, but you will have access to them, as Paige said. So Dr. Marsh, who you just heard speaking, is our clinical director and our attending neurologist at the Rett clinic. Holly Dubs is our genetic counselor. Myself, who's the nurse practitioner. Dr. Capovaro, who is our gastroenterology physician. Sam Pierce, who is our physical therapist. And Todd Levy, who's our occupational therapist. And the 6 of us all attend the multidisciplinary clinic together. Erica Schwab is our nutritionist at CHOP, who sees all of our Rett kids. She does not come to the multi-D clinic, but she does save appointments in the afternoon on the same day. So if you're seeing our entire team, you'll meet with the first 6 of us that you just saw in the morning, go to lunch, and then you could see Erica in the afternoon if your child has needs for nutrition. Mayori Canales is our social worker, and Odell Richardson is our clinic coordinator. So the benefit of coming to CHOP's Rett clinic is at the center is always clinical care. So we can be your primary team and take care of all of your child's neurology needs, or we can just support your local team. So for families who are out of state where travel would inhibit them from coming on a regular basis, if we meet you once a year, we can support your local team if Rett-specific issues arise. We also have the support of our social worker. So many of our families feel that the social work piece is a huge convenience and really help for them in accessing resources that they might not otherwise have known about. So here in the state of Pennsylvania, based on medical diagnosis alone, all of your children would qualify for secondary insurance, and the social worker can help with that. She can work as a school liaison. She can help you getting home health aides in the home and other supports that you might need in the home. And she can also help connect you to great Rett support groups like the RettSyndrome.org. And then the other benefit of being at the CHOP Rett clinic is the research arm. So by being seen as a CHOP patient, you have access to all of the novel medications that are currently being researched for Rett. And even if your child does not specifically benefit from one of those options, you are helping the Rett community at large when you participate in any of these studies. We currently have 3 appointment options, as Dr. Marsh was saying. So we have an in-person neurology only option, we have the in-person multidisciplinary option, and then we have telehealth. So if you choose to come in person, we want you to know that CHOP has pledged to keep you and your child safe during the pandemic. We're screening all of our patients 48 to 72 hours in advance of the visit. We're asking that no more than 2 healthy caregivers accompany the child to the visit to limit traffic in the hospital. We're asking everyone over the age of 2 to wear a mask, and we're following all CDC guidelines for cleaning. If you're traveling from out of state, there are some areas in the country that have been flagged as high areas of widespread transmission. CHOP updates these on a biweekly basis, and they are county specific, unlike the Pennsylvania Department of Health, which is at a state level. So CHOP has their own. It's very few counties in the country, but if you're coming from one of these counties, we would contact you in advance and let you know if there's any isolation precautions or testing that's required before you come in person. So the in-person neurology only visits are really helpful for our local families where we're your primary team taking care of all of your neurology needs. And these appointments are available on the first, second, fourth, and fifth Thursday of the month. We typically see our patients between the hours of 9 and 12 in the morning. And these are helpful for seizure check-ins, medication changes, to review any testing, and to get research updates. Our multidisciplinary team, which is what we're really excited about to have over the last year, this is to help you take advantage of seeing multiple specialists at once. So this is where you would be able to see both neurology, gastroenterology, and take the benefit of having our OT and PT in clinic. So this is held the third Thursday of the month, and we are looking at expanding this to twice a month as well. So during these visits, you're going to be in the room, the same room the entire time. It is a long morning. It's typically 3 to 4 hours in duration if you're meeting with the whole team. But once you get there, you don't have to go anywhere. Our team will cycle throughout the morning, and you and your child can stay in the room. There's a TV in the room, and you can bring any snacks or equipment that will help make your child comfortable during that time. And then, like we said earlier, if you need to meet with a nutritionist or have any other ancillary services, we'll give you a break for lunch, and then we'll help schedule those things in the afternoon. If you are a follow-up patient at CHOP, you can take advantage of the telehealth option. Currently, we're doing this for follow-ups only, and there are contracts with most of our neighboring states. So Pennsylvania, New Jersey, Delaware, New York, and Maryland all currently have contracts for us to do follow-up visits via telehealth. And the benefit of telehealth is that you can stay in your own home and you can connect to us using your mobile device. If you need any ancillary services, like your yearly EKG to check for prolonged QT, or an EEG or a swallow study, if you just let our coordinator, Odell, know at the time that you're scheduling the appointment, we will try to get those scheduled for you in the afternoon, the day that you come to see us. If you need to see a specialist outside of our multi-D clinic, like cardiology, orthopedics, or pulmonary, if you're traveling from out of state and you're going to be staying here for your Rett appointment, we would try to get those the day before or the day after to make the most of your trip. But they're typically not available on the same day just because of the time constraints, because the multi-D clinic is so long. CHOP also offers a speech and language evaluation to help get kids augmented communication devices, which, as many of you know, is really a great way for our Rett children to be able to communicate with us. This at CHOP is a two-step process. The first is getting a speech and language evaluation, which takes about 90 minutes. If your child has had a recent speech and language evaluation through school or has a recent IEP, you can use that and skip this first appointment. Once that's complete, they'll schedule an actual session to practice with the different communication devices. And these are typically 2 separate sessions, about 2 hours in length. And the speech and language pathologist will work with your child trying out multiple devices to see which one best kind of suits the needs of your child. And then they can give you a loaner while they're trying to get that covered by insurance. And so we included the number here on the bottom of the slide. If this is something you want to take advantage of, you can go ahead and call. Even if you're not a patient through our Rett clinic yet, you can still call and schedule to have this evaluation done. A few things to know about the multi-D clinic. Just based on insurance, it is varying based on provider. So if you're seeing both neurology and gastroenterology, that would require 2 referrals. Our coordinator, Odell, is great at working through insurance issues, and we'll keep you up to date on what you need to get from your pediatrician. He'll also help you with knowing your benefits. So many insurance plans will limit how many physical or occupational therapies you're allowed to get each year. And our goal through the Rett clinic is to support your local team and to give them ideas on how to better serve your child. We don't want to use up any services you have. And so Odell will work through all of these issues with you. And there are copays that are collected per specialist. So if you're seeing the multi-D clinic, but you're seeing 2 or 3 providers, each specialist does require a copay. So if you'd like to come meet us at CHOP in any of those options, whether it's the multi-D clinic or neurology only, you can give us a call. Odell's number is listed here, or you can email Holly Dubs, our genetic counselor, or if you're a known CHOP patient through any other department and you have access to MyCHOP, you can send us a message via MyCHOP anytime, day or night. And if you don't remember anything else from today's talk, the 1-800-TRY-CHOP is the number that you can call, and the person who answers the phone will be able to connect you with the correct department to help you schedule with us. So we hope to see you at some time at CHOP. The next speaker is going to be Todd Levy. He is our occupational therapist. And so we'll turn over the slide deck to Todd.
Thank you so much, Erin. And as Todd's coming online, I just want to remind everyone that if you have questions for any of our speakers, go ahead and type them into the chat field. And thank you, Erin, so much for giving a beautiful overview of your clinic. Thanks, Todd. We see your screen and bring your slides.
Yes, hello, everyone. I'm just going to try and pull up my slides here.
All right, and while they're coming up, I'll just remind everyone that we are recording the session, so you don't have to worry too much about taking notes. But do type in your questions. We'll get to them all at the end after our presenters. And there we go. We're coming up into slideshow view in a second. Isn't this fun? All of us virtually working from home and managing technology across all these platforms.
I think I've got it. Okay. So I'm Todd Levy. I've been an occupational therapist at CHOP for about 17 years. If you come to our multidisciplinary clinic, you're likely to see me. So what in the world is occupational therapy? Even those of you who have worked with an OT for many years, you might still have that question, because unfortunately, if you ask 10 of us, you will get 10 different answers. And I apologize for on behalf of my field for that, because it is quite confusing and it's a very broad field. I'm going to try and kind of unpack all the things you may have heard and experienced about OT. I think it's pretty safe to say that if your OT is not focused on helping your child engage and participate in activities meaningful to her, they're probably not doing their job, and you need to shop around for a new OT. I don't think any OTs would really disagree with that. That's the heart of occupational therapy. And what's meaningful to one is not meaningful to another. So this is very, very personalized. It could be self-feeding, it could be controlling electronic devices, it could be engaging with specific toys or books. And you can help us help your child by telling us what they do enjoy or what they seem to want to explore, or maybe it's something that they seem to like, but they physically drop it in 30 seconds for some reason, and you want them to engage in that activity for longer periods of time. So the pictures just show kind of a very big diversity of activities. A lot of my years of my career.
Todd, I'm sorry to interrupt you, but I think your slides aren't advancing.
Oh, I wonder if there's a delay.
We're still on the home slide.
Really? Because they're advanced on my screen.
I'm so sorry. I just don't want anyone to miss your wonderful points.
Are you sharing the correct screen, Todd? You know how there's options? There you go.
There we go. Okay, thanks. Sorry for disrupting.
No problem. No, thank you. So the pictures just show, there's quite a diversity of activities that all humans can participate in. A lot of my collection of photos come from stroke and traumatic brain injury. So sled hockey is a great activity for a lot of those children. But I do want to say we don't really prescribe activities. We try and think about how can we engage your child in whatever it is they seem to want to do. So we try to not have limitations in our thinking about what those activities are. Sled hockey is something that's up here that hopefully you can see my pointer. It's a really interesting sport. It's now a high-level competitive para-Olympic sport that people with a whole variety of disabilities can engage in. And my buddy Paul here, I've been working with since he was 6. He's now about to enter college. He had a severe lack of use of his right side and a lot of anxiety, and he was able to overcome both to the point that he went from having someone push his sled to being able to propel his sled and hit the and pass the puck and score goals. And rock climbing is just I'm just pleasantly surprised almost constantly by how much anybody can engage and benefit in rock climbing, especially when we adapt it. Self-feeding, that's one of my favorite activities, and could be for many of your children, so that's definitely a role of OT. And then a little bit more specific to Rett syndrome is we do have a role in helping to reduce self-injurious behaviors, and then accessing communication devices. And I'll talk a little bit more about both of those. So turning to stereotypies and self-injurious behaviors, the circles kind of is a structure that all OTs know and consider. We think about aspects of the person, the environment, and the activity or occupation that they're trying to engage in. And aspects of all in all these areas interact to influence either the activity trying to be performed or the behavior, like a self-injurious behavior. And we can think about, what can we manipulate in each of these circles to help achieve goals in these areas. So if it's reducing self-injurious behaviors, are there aspects of the person that we can change? Are there aspects of the environment that we can change? The environment can be busy, noisy, lots of lights. It could be an environment where your child is getting a lot of attention, or it can be a very boring environment, quiet environment, an environment where your child does not tend to get attention. And then the activity can be modified. Is it challenging? Is it so challenging that it's causing frustration? Is it not challenging enough so that there's not really like motivation to engage in? Is it boring? Are hands being used in the activity? If hands are being used and the hands are occupied, perhaps that will reduce self-injurious activities. So just some different areas that specifically that we can kind of intervene to reduce self-injurious behaviors. You probably all know that splinting and bracing can be used. In terms of evidence, there's very little in the literature, and what is in the literature is mixed. Whenever there's mixed evidence, it just really tells us that you, the parents, and us, the therapists, have to monitor the effects on your child. If it doesn't seem to help for your child, stop. It's a waste of time. And if it is, great. So kind of be prepared for trial and error, and that's going to be the case with a lot of interventions, unfortunately. But I think if you bear with us and allow us to go through a trial and error process, we'll find success. There are behavioral interventions, and there's at least very good indirect evidence here with other populations, autism and traumatic brain injury. Medications, the role of an OT when it comes to medications is just going to really be communicating with the medical team. So to say, look, Dr. Marsh, Aaron, this family has tried everything. We've modified all aspects of the environment we could think of, and we've used splints, and we've tried to change, engage them in different occupations to occupy their hands, and multiple. I've connected with other colleagues for their ideas, and we're just out of ideas. Can you maybe consider some medications? And for the sake of time, I'm going to advance a little bit here. Just to go through just quickly some non-splinting interventions. And this is something that parents, we really need your help with, your input, and where it's important for you to journal and write a lot of things down. So one thing that we look for are what we call antecedents. What is happening either to cause the self-injurious behaviors, or not necessarily, it doesn't necessarily seem to be a cause, but just what is happening immediately before you see the behavior. And it can be anything under the sun. It can be as nuanced as like it's the temperature's chilly in the house or warm in the house, or it's raining outside. It could be something that you're not really thinking about. So really write down, when you see the behaviors increase, just write down what's going on today, or what happened, an hour before, 5 minutes before. Really keep a journal and bring that in for us to see. So for example, if you notice there's really, vigorous hand wringing that has been damaging to my child's hands in the past, I notice this is happening after I walk away, well, then we can start to strategize. Are there things you can do? Because sometimes you need to walk away. Can we set up some sort of engaging activity that will take their mind off of that and occupy their hands? If we set up a video for them, will you be able to walk away and turn your back for at least 5 minutes? And then with environmental modifications, same thing. Make some notes. What seems to be increasing or decreasing the self-injurious activities. So if you notice my child is really mouthing their hands more in noisy environments, or your OT can help you strategize. You can't always avoid noise, but sometimes you can reduce it in creative ways, and sometimes we can just help prepare your child for that environment, and that can be helpful. And then occupation. So are there things that tend to occupy your child's attention or their hands, even for 5, 10, 20 seconds? So if you come into clinic and say, they really seem to like be happy and be engaging with a stuffed animal, but it's only like 10 seconds and then they throw it on the floor, well, then we can think about ways to increase that length of time that their hands are engaged in that activity. When it does come to splinting, which we don't like splinting to be the first option. Bear with me here. We like to start with the smallest, what we call low profile splints that don't cover a lot of skin, don't cross many joints, because we want joints to be free to move and to for joint health over time and muscle bulk. So here's an example of some sort of low profile splints that could be even further modified. This is a company called Bennick that makes some relatively small splints, and sometimes you need an OT to modify these further or to fully customize. These are sort of semi-customizable splints. You can project individual fingers, multiple fingers. There's this stuff that Bennick has called textured tape that can be added to spots that your child really mouths or bites a particular spot. You can add this textured tape to that spot. Now, Bennick will say, disclaimer, this is not meant to protect against like real full-on biting. But in many cases, it at least helps to protect against the saliva that can cause skin issues, and it can at least allow you to like turn around and take your hands off for short periods of time, and give you a chance to intervene when you notice that they really are biting so hard that you need to do something in addition to the small splint. Many of you have seen different elbow bracing. We're kind of moving up to some more restrictive bracing, and we try not to restrict. Some of you have seen these bamboo braces that were designed for a different population, but some parents are finding some success with this with their children with Rett syndrome. They've got these inserts that have variable amount of flexion pliability to them, so you can kind of play around to see is there a level that we find where my child can move their elbow enough that they're exercising the joint and can participate in some activities, but they're blocked enough that they can't do what they can't injure themselves. Then there are hinged braces, some which are semi-customized, some which we fully customize, and they're a little bit more sort of specific in the range that we can allow and block. There are some that we fully make in the clinic that an OT can make. They're kind of creative, that allow, in the bottom picture, you can see it's the same brace that allows you to fully extend the elbow, but it blocks bending of the elbow to whichever point that you design the splint. There are things called comfy splints that are, if they work, they do immobilize, but they can be quite comfortable and easy to clean. And there's an endless amount of possibilities. It's not a one size fits all, and a lot of times you have to try more than one so you find really what works. Our role in communication devices, I think I like circles. There's sort of 3 areas to think about. One is obviously language, and it's really your speech language pathologist that's gonna really best assess this and decide, what is your child gonna say with the device. How many options should there be in the screen? Is this going to be a low-tech device? Is this going to be a high-tech device? And then when it comes to now I have the device, like any device, like a computer, if you're laying on your couch and reclining, you're not very effective at typing and using your mouse, or you're going to have, carpal tunnel over time or something like that. So positioning is very important, and that's going to be either OT or PT or a teamwork between both to set up your child in the best position to use the device. Then there's accessing the device, which is really where OT is going to come into play. It's not always going to be something that we need to address, but if need be, we're going to help determine, are they going to be best, more accurate using their finger or stylus? Should it be mounted to a wheelchair and to the right or to the left based on their vision or their comfort? Should it be on a lap tray? What kind of, do we need a switch? So it's really the point of access that's where OT comes into play. But again, teamwork. Just finally, things to prepare for your visit or for your OT that maybe comes to your home on a regular basis. Write things down, because I think especially these interdisciplinary, multidisciplinary team visits are very overwhelming, and it's hard to even get to your appointment on time, especially in the city. And it's hard in the moment to think about all these things. So come with lots of notes. Think about those antecedent behaviors, what's happening before the self-injurious behaviors, what environments seem to be increasing or decreasing them, what does your child enjoy or seem to enjoy, what engages them, what are your everyday frustrations. And then try to bring your splints. Pictures can be good too. And then pictures and videos of your child participating in activities. Awesome, because the medical exam room is the worst possible place for an OT to assess a child. It really makes no sense for us to be assessing your child in an exam room, except for the fact that the full team is there, and that's a giant benefit. So with the exception of being able to, it's a nice environment for us to do a hands-on assessment. It's not a good place for us to assess like real life skills. And last but not least, I think silver lining to the COVID cloud is, at least for the time being, we are allowed to do telehealth visits. So in some cases, it will make sense. I might say, so I'd like to do a follow-up telehealth visit with you and really watch what you're telling me in the house where it happens, or maybe even in the school where it happens. So that's a little bit trickier to do, but but bring videos and pictures. We do like that very much. So yeah, I think we are ready to turn it over to Holly Dubs, our genetic counselor. And there's my email address.
Todd, thank you so much. This is Paige Nues. While Holly's bringing her slides up, want to thank you for all of that wonderful information. A lot of families always have questions about how an OT can be a part of the team, and you're a very critical part. So thank you for those insights. And Holly, we welcome you to the webcast today, and it's good to see you again.
All right, thanks everybody. So I am going to switch gears a little bit and introduce our research program. You heard mostly about our clinical program from Erin. And so as Erin mentioned, our clinic really is comprehensive. So being seen at a Rett syndrome center really allows us to bring all those pieces together, involving both the clinical care aspect as well as the research aspect. And we can really kind of think about our research arm in two separate parts. So first are interventional clinical trials, where we're actually doing something to try to treat or manage some of the signs or symptoms of Rett syndrome or the condition as a whole. And then also the observational aspect, where we really gather information and learn more about Rett syndrome. And we do that through the natural history study, which I'll talk a little bit more about. It takes a lot of people to coordinate all of this and to keep all of this working and moving. So in addition to Dr. Marsh, we also have Dr. Kessler, one of our other neurologists, who has been working with us to see patients through our different clinical trials, and Dr. Sabi, who some of you who are at our Rett Ed Day may have heard from in the past, who really does a lot of the analysis for one of the arms of the natural history study that I'll also talk about. We have several clinical coordinators, Sarah, Emily, and Rashmi, who really help make make sure that we keep things running smoothly, as well as Sam and Brian, our research nurses, who are really critical to making sure that we're able to conduct these studies. And they'll talk to you a little bit more shortly about some of the specific clinical trials that we have ongoing at CHOP. So if you are curious in terms of learning more about research, I think due to time limitations, we're going to focus mainly on what's available through CHOP. RettSyndrome.org has launched 2 great tools on their website. So they have a Rett Research Ready page that talks about research overall, talks about what it's like to participate in a clinical trial. And then they have a really great tool called My Rett Trial Finder. So clinicaltrials.gov is a global access website that talks about trials and research that are available for any condition, essentially, which can be a little bit overwhelming. And it also includes historical studies, studies that are just moved into the data analysis phase and aren't really actively recruiting. But My Rett Trial Finder really compresses that down and focuses on trials specific for Rett. And so you can use that tool to enter your geographic area, your child's age, things like that, to narrow down to studies that may be the most relevant for you, and also to be alerted for new Rett trials as they become available. So if you haven't already accessed that, or if you're not familiar with it and you're interested in getting more involved with research, then I would definitely encourage you to check that out. So I just wanted to briefly introduce the natural history study. I know some families may already be involved or have been involved in the past, but the purpose of a natural history study is really twofold. The first is to really help to describe the clinical course of a condition over time, independent of any particular intervention. So what is the clinical course of girls with Rett syndrome? You know, what age do we typically expect to see a regression occur? What age is it most likely, you know, what is the age range where scoliosis typically develops, things like that. And we know the answers to many of those questions because of data that we've already accumulated as part of the natural history study. And this information is particularly useful because it provides great data to be used when someone wants to potentially initiate some sort of clinical trial or other interventional study. So in order to know if a specific treatment or medication is working, we have to know what the course would have been like otherwise, and that's really where the natural history study data comes into play. And so part of what has made Rett syndrome and the Rett syndrome community kind of a leader in access to clinical trials is that we have this great wealth of knowledge and great wealth of information to draw on that's really poised Rett syndrome to be sort of ahead of the pack in getting new clinical trials up and running. And so the current natural history study is a continuation of a prior study that had enrolled approximately 1,200 patients and individuals. The current study is collecting data from people across 15 recruiting sites. We're enrolling individuals with not only Rett syndrome, but related conditions, including other MECP2 alterations, MECP2 duplication syndrome, CDD, and FOXG1 related neurodevelopmental disorder. And so far, we've enrolled 121 patients from CHOP, which is awesome. And I think it exceeded our initial expectations. The study was originally designed as a 5-year study and due to wrap up this past July, but we've been able to extend the study for another year and certainly expect to continue to work with RettSyndrome.org, some of the other groups and other sites to be able to continue collecting this type of useful information even after this official version of the study is wrapped up. And so what a natural history looks like, it's not too much different from your regular clinic visit. We may ask some questions a little bit more in depth than we would if we were just collecting clinical information. And then parents usually get a little bit of homework, including a few questionnaires that we ask them to fill out either before, during, or after the visit. But overall, it's an annual visit for children who are between the ages of 1 and 10. Visit every other year for children between the ages of 10 and 20, and for our adult patients, we see those patients every 4 years. The initial visits do really tend to have to be in person just because of some of the logistics with consenting and things like that, but our follow-ups we're able to do in person or remotely. Obviously, we're a little bit more limited in what types of data we can collect remotely, but I think some data is better than no data. And then there are two other study options that people can elect to participate in, which include biobanking and the neurophysiologic correlates. So for the biobanking study, the goal is to collect biologic samples that can be used as a source for future research. So to have specimens available for to run different types of studies as needed in the future or as we continue to learn more. They're also looking to see, are there other types of either genetic markers or other levels of things that can be detected in blood that might help give a better understanding of why Rett syndrome is so variable, or what might help influence the severity, things like that. And then the neurophysiologic correlates, I'm going to just talk a little bit more briefly. So this is a slide that was generously provided by Dr. Sabi, who's doing the analysis of this study at CHOP. And the purpose is really to identify brain-based measures of brain function in individuals with Rett syndrome that can be used for assessing the effectiveness of new drugs. And this can be really useful because for many of our clinical trials, we're relying on symptom-based questionnaires. So we're asking parents to report on, are you seeing symptom A more frequently or less frequently than you had been previously? Or do you feel like this is mild in severity, moderate in severity, severe in severity, things like that. And you can imagine as parents how difficult some of those questions might be to answer, and how the distinction between some of those things might be a pretty small difference. And so having a more objective and a more sensitive test might help to be able to allow us to identify subtle changes more easily than relying on sort of traditional self-reporting. So far we've enrolled over 70 girls with Rett syndrome across 5 sites, and Dr. Sabi and the CHOP team are really the central site that's responsible for analyzing that data. And what this study is looking at, it's essentially very similar to an EEG that your child would have if there was a concern for seizures, where they have a cap placed on their head with different electrodes hooked up, and then they receive both visual input, so different like patterns blinking on a screen, or different noises that are played, and this study measures the response of the brain to those different stimuli. And I'm not going to go into detail here because it's beyond the scope, but these two graphs at the bottom are showing brain waves that are measured in typically developing children in green, compared to girls with Rett syndrome in blue. And you can just see very easily from a quick visual look that those patterns do look a little bit different. And so we're trying to translate that into a useful measure. Does this correlate with severity? Can we use this to predict overall clinical course? Can we use this to measure response to drugs? So if you have the opportunity to enroll in this aspect of the natural history study, it really is potentially providing really useful data. And so overall, this really has provided us with great sources of information for a whole host of angles. So as a genetic counselor, one of the articles that's most helpful to me is an article looking at what we call genotype-phenotype correlation. So I know families often ask, can we predict the severity at all? And we do know some information about what particular MECP2 gene change is present and how that could potentially influence the overall severity or the correlation with particular symptoms. We've also recently, Dr. Marsh and team has published a study looking at comparison of symptoms in Rett syndrome compared to some of the other conditions that are included in this study. What makes Rett syndrome different from CDD, for example, or how are those conditions similar? And then last but not least, which is going to be immensely valuable to your families, are that there were recently published consensus guidelines on the management for Rett syndrome. And so this is a particularly helpful tool maybe for families who don't have easy access to a Rett Center of Excellence or clinicians who are particularly familiar with the condition. This provides guidelines that can allow local providers to be providing, the same type of care and the same standard of care as physicians who may have more familiarity with the condition. So with that, I'm going to turn it over to Sam to talk a little bit more about what it looks like to participate in a clinical trial and be a participant in more active interventional research.
Thank you, Holly.
Thanks, Holly.
Okay.
You're welcome. Getting started, go ahead and please type in any questions you have for our presenters, and we'll get to those at the end of our talks. Okay. Thanks. Go ahead.
All right. Thank you, everyone. Thanks, Paige. So my name is Samantha Hagopian. I am a nurse study coordinator at Children's Hospital of Philadelphia. I'm part of the team that does clinical trials around Rett syndrome, CDKL5, epilepsy. And so I wanted to talk to you all today about what clinical trials are and what's involved in them. If you have not yet participated in a clinical trial before, you may be wondering how they work. And so first important is to know what they are and why they are important. And it's really they're necessary for medical advances. The goal is to determine if a new test treatment not only works, but it's safe too.
Sorry to interrupt, but I think your audio is a little scratchy and I don't want anyone to miss your important information.
Oh, I'm sorry.
Yeah, can you
maybe
put
if
on
I
your
get
headphones real quickly?
Sure. Sorry about that.
Oh, it's actually might be cleared up.
You hear me okay still?
Yeah, now we can.
Okay. So I'll just backtrack a little bit to just say that clinical trials are necessary for medical advances. The goal is to determine if new test or treatment not only works, but is safe as well. And they can also look at other aspects of care, such as improving the quality of life for people with chronic illnesses. And so here you see the drug development process, which starts with preclinical research, which is the discovery and testing in cells and animals. Then you have first in human studies, which often occur with healthy adult volunteers. And then next, the study is applied to patients with the diagnosis of interest. And that initially is to test for safety and tolerability, and then followed by if the drug actually works. And only 21% of these drugs actually make it to the market. And then once they do, the FDA requires frequent monitoring even after the drug is approved. Oops. Shoot. What did I just do? Can everybody hear me? No?
We can hear you.
We can hear you.
Slide.
Sorry, I lost everything. I'm so sorry. I can't see, like my whole computer just went blank. Do you guys see my screen?
Yeah, we still see your screen, Sam, and we still hear you.
I am so sorry. Oh, there you go. I'm so sorry about that. I apologize.
Yeah, we didn't lose you. We're on the drug development process slide.
Yeah. Sorry, it went blank and I got really nervous.
This is quite a feat to do this across so many home broadcasts, but we got it. Go ahead.
Okay, thank you for your patience. So after the preclinical studies occur, then the human studies can begin. And how to find out about clinical trials that may be available to you is first ask your doctors. Most clinical trials have websites with information on them, and you can always go to clinicaltrials.gov. But most importantly, before participating in any study, make sure that you talk to your provider about the risks and benefits about the study and just make sure that it's right for you. So this is an overview of the process of the clinical trial. And so they have many visits throughout the trial, and some trials are shorter than others. Some trials last a month or two, and some trials last a few years, depending on the medication being looked at. The first visit is a screening visit, and this is often the longest visit throughout the whole trial. All studies start with the consent process. No study procedure should take place until this informed consent process is done. And what that entails is the study team.
You were breaking up for a second again, but now you're back.
Okay. The study team will review the study consent form with you and the procedures of the study. They will review the risks and benefits of the study and the medication, the study procedures that are going to be done during the study, and what other treatment alternatives there are as well. So once you have time to review that information, you make sure that you ask all questions that you have and that the study team answers those questions. And once that's done and you want to continue with going ahead with the clinical trial, then you sign the consent form and make sure that you receive a copy of that consent form that has lots of information on it that you can refer back to during the course of the study. The screening visit, like I said, it's a long visit, and it's helpful to prepare with a few things. We'll be asking you questions about prior diagnoses, surgeries and the dates of those surgeries, all medications that are current or previous, and the start dates of those medications. So if you come prepared with those dates and that information, it just makes things go a little quicker. And then also, because it is a long day, you may want to bring some snacks and some drinks. And if you have other children at home, you may need some childcare. And because many times there is blood work done, drink plenty of water, have your child drink plenty of water beforehand, so making lab draws a little easier. And some studies require urine samples. So if you don't think your child will be able to give a urine sample later in that day while you're on site, then you can always get one in the morning and bring it in with you. Okay, like I said, there are many visits in the trial, and this is generally a grid of what it could look like. This is most likely in your consent form, and it would be a great idea to sit down at that first visit and just plot out and schedule those future visits, just to have a plan. Life gets really crazy, and it's nice to not have to worry about when the next visit is in a few months or in a few weeks. So have that planned out ahead of time. Like I said, there are many procedures that could be part of the clinical trial. These could include blood work, questionnaires, EKG, EEG, depending on the type of study. After the screening visit comes the baseline visit and randomization. So in the baseline period, it may last 4 to 6 weeks, depending on the study. And this is just a period to collect more data, baseline data, such as seizure information, sleep information, behavior information, and this is often collected in a diary. Once all the information is collected and study eligibility is confirmed, then the randomization can occur. And the randomization is a process in which the placebo or active drug is assigned to your child. And this is randomly assigned by a computer program. Most studies are double-blind, which means you nor your provider or study team will know which medication you are receiving. Some trials, but not always, are randomized 1-to-1, which means you have a 50% chance of getting placebo and 50% chance of getting active drug. So basically you're flipping a coin. Others could be 2-to-1, which means that you're 2 times more likely to receive active drug than placebo. And after the randomization visit, you will enter in the titration and maintenance phase of the study. The titration visits often occur really close together just to maintain safety while the dose of the medication is ramping up or increasing. And then the visits will spread out during the maintenance phase. You may be required to complete a study diary, maybe for seizures or meals, behaviors, or sleep. And you'll need to bring those back at every follow-up visit with you so that the study team can review that information. It's important during the study to report any changes in your child, any illnesses, any hospitalizations during the study. And this is just closely tracked and correlated the possible side effects of the study treatment. And then after that is the end of study visit. Now, you can leave the study at any time for whatever reason. So the end of the study visit doesn't always end after all the other visits in the study. You may also be asked by your study team or the provider to withdraw from the study if they deem that it's not safe for you to continue into the study. Above all, the safety of your child is most concern. And if you do complete the study, most phase 3 studies have an open label extension phase. So in that part of the study, you know that you will be getting active drug, no more placebo. And again, the double-blind study, you will not know, nor will your provider know what treatment group you're in, even after the study ends. So after hearing all of that, why participate in a clinical trial? So there are lots of benefits. First, you're gaining access to new treatments before they are available to everyone else. You're helping contribute knowledge to this medication or treatment, and you're receiving closely monitored care by the healthcare team. With all those visits, you're going to see us a lot. And then the treatment costs may be lower at this time as well. Many of the tests, treatments, visits that are directly involved with the study are paid for by the study sponsor. And some studies even offer you a stipend for your time and to cover travel expenses. And then some risks of the clinical trials is, like I said, it's a big time commitment. There's frequent visits, there are long visits. You may not be able to change your other medications. So if your child's experiencing seizures and they're on seizure medications, some clinical trials ask that those remain unchanged during that time. And that's really just to ensure that any changes that are seen in your child, we know that are from the study drug and not from the other changes that were being made. And then another risk is more frequent tests than your doctor normally would have you do, like blood tests. And lastly, there's always the chance of receiving placebo instead of the active drug. So the Center Watch Center for Clinical Trials did a study, and they found that regardless of the perceived risks and benefits, 98% of those studied would consider participating in a clinical trial again. So we've had a lot of success with families in our clinical trials. Some medications work and some don't, but that's why we do clinical trials. We love having families participate, and we love getting to know our families during that time that we spend a lot of time together. And now I'm going to hand it over to Brian to discuss what clinical trials we currently have going on at CHOP. Thank you.
Samantha, thank you so much. That was great information and a great orientation to the clinical trials happening at CHOP. Brian, we welcome you.
Hi, thank you guys. So like I'm Brian, I'm one of the nurses that work with Sam. It's basically just Sam and I who do all of the trials together. Let me just, can you guys see my screen?
We can see your screen if you want to go into slideshow view.
Yep. All right, so now that we're in slideshow view, let me just get this out of the way. Sorry. All right, so right now for our Rett syndrome girls, we currently have 2 trials that we are running, and I'm going to go through those 2 right now. So the first one is for a novel drug called TROFINETIDE. It's sponsored by ACADIA. Right now we're in the phase 3 trial of this study. So as Sam had talked about before about our double-blinded placebo randomized trial, so that's what this study is for. So in this study, your daughter would have a 50-50 chance to get placebo versus trofinetide. And as Sam had stated, neither myself, Dr. Marsh, or the family would know which version of the investigational product that you're receiving. This study currently is for all females between the ages of 5 and 20 years old. Right now, this trial lasts about 12 weeks. Over those 12 weeks, you will have 5 in-person visits with myself, Dr. Marsh, and Sarah, who is the study coordinator on this study with me. The first visit is basically just gathering medical information, updating the medical information we have on file, going through medications that your child takes, any other past medical history that may be pertinent. And then this part of the study, we also get lab work and ECGs on every single visit that you're here, just to make sure that the investigational product isn't causing any untoward side effects that we're not aware of. The second visit during this 12 weeks is the longest visit. So if the first visit goes well and the lab work looks good, ECGs look good, and data supports that it would be beneficial to enroll into the trial, we would then randomize your daughter onto placebo versus trofinetide. And that would happen at the second visit. So that's a long visit. That visit typically is anywhere between 5 or 6 hours by the time we collect all the data we need, randomize you onto the investigational product, monitor you for a little bit longer, do some repeat ECGs and lab work, and then send you home with the rest of the medication for the next week or so. After this part of the trial completes, if you complete the entire 12 weeks of this trial, you then have the option to roll over into a 40-week open label trial of trofinetide. So that last visit, so visit 5 would be visit 1 of the open label trial. And at that point, you would give me back whatever you're on, whether it be placebo or trofinetide. And then at that point, you would definitely receive the trofinetide medication. So the primary objectives of doing the trofinetide versus placebo study is to see if we can demonstrate that there's any positive effects of using trofinetide on Rett syndrome as a whole. So the things that we look for are, does the trofinetide have an improvement in the overall quality of life of your child? Does it help to improve our ability to communicate, either whether it be verbally or to make choices by eye gaze, or if your child has the ability to reach out for objects, grab objects? We also like to assess if it helps with things like ambulation. If your child does not ambulate, we would look at things like gross motor skills as a whole. And then, like we had mentioned, we would look at overall severity of Rett syndrome. Oh, sorry, I hit the wrong button. Let's go back up. So what does the investigational product look like? So it's a strawberry flavored liquid. It would be required to be administered twice daily. You need at least 6 hours between doses. So typically we just say that if your child is on other medications that get twice daily, you can give this at the same time you give all the other medications to make things simple. And it can either be given orally or it can be given via G-tube. At this moment in the trial, I have subjects who take it orally and I have subjects who take it via G-tube. The biggest drawback to taking orally is just it's a new medication and a new flavor that your child has to get used to. The medication must be refrigerated. It's a large volume of medication, so the sponsor actually offers the families an option to have a second refrigerator delivered that's paid for by the sponsor in order for you to simply store the medication and only use it for medication storage. The biggest side effects that we see with trofinetide study is diarrhea is number 1. And what Dr. Marsh and myself and the sponsor have talked about is if your child currently receives any medications for constipation, things like Miralax or anything else like that, we typically tell you on the day that we're going to start the medication to stop giving those bowel movement medications, because that way if there is diarrhea, we can try to make it less severe than it could be with the other medications. The other option or the other side effect that we see second most would be vomiting, and the upper respiratory tract infections is the third most. The other interesting thing about using this company with this investigational product is typically with our studies, either Samurai will give you all your medication while you're here on site. With the trofinetide study, I only give you the medication on the visit when I dose you at the hospital. After that, there's a home care company, nursing company called PCM. They will deliver the rest of all the investigational product to your house and collect all the empty bottles at those visits. So you won't be required to bring medication back and forth at each visit as you do with many of our other studies. And as I had mentioned previously, at each of the 5 visits, we will get lab work at each visit and we will get ECGs at each visit. And that's just to ensure safety. And then, like I said, at visit 5, which is week 12, you can have the option to let me know if you would like to roll over into the open label study. And that doesn't have to be decided at the beginning of the trial, at the middle. We can just decide before that day that that's what you would like to do so that we can make sure that everything is in place to move over into the open label trial. And then we will move on to the next study. So the second study we have is actually for a known medication. So it's actually for the use of ketamine in Rett syndrome. So the interesting thing about the ketamine for Rett syndrome trial is that's a randomized double-blind trial with a crossover phase. So in this study, there'll be 2 dosing phases. There's going to be a dose where you definitely get ketamine, and there's going to be a time when you definitely get placebo. And when that happens, none of us will know which dose you are getting except for my pharmacist. And I'm not sure why my Rett syndrome research trust slides slid over into my notes, but It's for females between the ages of 6 and 12, and it has to be pre-menarche. So at any time your child were to start her period during the trial, she would have to be removed from the trial for safety purposes. The great thing about this trial is it's only 29 days and it only involves 4 clinic visits. So the first visit, you guys come in, we do the normal thing we do for trials. We update medical history, update medications, and then we dispense what is called a hexoskin, which is a smart shirt, and an actigraph, which is a watch. And we send you home with those devices for the next 20 days to collect data for things like movement, heart rate, breathing rate, sleeping patterns, and all that data is collected and downloaded into our system. Then we bring you in later for the final 4 visits. The primary objectives for this study is to assess the effectiveness of ketamine related to things like activity, the movement that your child demonstrates, heart rate, gait, sleeping, posture. Are they able to sit up better? And then breathing regularity to see if it affects things like breath holding spells that a lot of Rett syndrome girls have, or the hyperventilation that our subjects tend to show. And then the ketamine, as I discussed, so it's ketamine versus placebo. And this again is an oral liquid that you take twice daily. So on the second visit, should everything look good as far as lab work and testing goes at our first visit, at that visit, I will administer the first dose of either the ketamine or the placebo while you are here at the hospital. You then kind of hang out for 2 hours just so that I can assess that your daughter's responding appropriately to the medication and not having any poor side effects. And that'll be done through monitoring of vital signs and just disposition and behavior. So I will then give you the remainder of the 5-day BID dosing to go home with. And then for the next 5 days, you dose at home twice a day. And then after that, for another 10 days, you use the hexoskin and actigraph to collect the data that we're looking for improvements. Day 15, you guys have your another visit, which is another dosing visit. So if you received ketamine on the first dosing days, you'll then get placebo on the second. And again, I myself, Dr. Marsh, and you as a family will not know which 5 days is ketamine and which 5 days is placebo. But again, through this 29-day trial, you will receive both versions of the medication. Again, it's administered exactly the same. You're going to take the first dose while you're here on site. The remainder of the 5 days will be taken at home. And then we'll again assess things with the actigraph and hexoskin for the next 10 days until we bring you back for the end of study visit. And then that kind of is a quick overview of all our studies. Each of our studies, I should have mentioned, require that your medications remain stable. So if you take any anti-seizure medications, specifically, those are the most important, is that those remain stable for at least 4 weeks. And then any other medications, supplements, treatments that your child may receive needs to be stable for at least 4 weeks prior to the first day that we screen you for whichever trial you feel is most appropriate for your child. And the reason that they do this is, like Sam said, is to make sure that, is it the investigational product that we're administering that is making improvements, or is it a combination of other changes in your medications or therapies? And then with that, that is the end of my slides, and we can ask questions at the end if any families have further questions or want a little more detail about each study.
Great. Thank you so much, Brian. That's incredible information. And I'm going to go ahead and take back control here of the slides. I have just a few pieces of information and updates from rettsyndrome.org, and then we're going to go to QA. So thank you to all of our presenters. We know it's been an incredibly intense summer and fall for you, and we're so grateful to have you with us today to share all of the updates of the continuity of care and research at CHOP. And okay, so what I'd like to do, because we are scheduled to be together for an hour and a half today, and we've had a lot of information, I just want to share a few brief updates about what's been going on at rettsyndrome.org this summer, because we have produced some incredible things for you that should be helpful in your life, especially as you're navigating virtual school, online learning, and all research, engagement, and care. So real briefly, I just want to let you all know that we have not stopped in our commitment towards research. We are continuing to invest in all areas of research, including gene therapy and RNA editing, X reactivation. We didn't have time today to go into all of that, but we have some wonderful webcasts that have recorded and talked about where we're at with that therapy and with that research, and I'm going to talk a little bit about that in the QA session. We also have invested in the development of a clinical network, as you know, across the country through the natural history study and others who aren't part of the natural history study, but are clinics in the country to serve as clinical trial sites and experts in Rett syndrome. I know we have a lot of families on here who may or may not be in the immediate area of Philadelphia, and we encourage you to visit our website to see all of the clinics across the country. Also, you might move. You may be planning to stay in the city where you are in, and you might move. So we want you to visit our website and know that there's an entire network across the US who are there to serve you, in addition to the wonderful folks at CHOP. Who also serve on our medical advisory board. So we want to give a shout out right now to Dr. Marsh and the entire team for serving on the medical advisory board, and as Holly mentioned, helping develop the primary care guidelines, which are produced and ready and available for you, so that if you're not being served by a Rett expert clinic, we do have a checklist of guidelines that should help your pediatrician and your child's GP help you navigate what sort of tests and symptoms and things should be looked out for that we commonly see in Rett syndrome. I'm not going to talk anymore about the Research Ready program because, Holly, that was wonderful of you to talk about this program that we rolled out over the summer to answer questions about what it means to be in a clinical trial. And there's some videos and things. Again, you have a great team at CHOP who can answer all of these questions for you. But in addition to the clinical trials that Brian talked about, there are some virtual research opportunities, and they are in the MyRett Trial Finder. Specifically, we have a couple of organizations that are looking at how the COVID pandemic has affected us as people who are living with loved ones with a rare disease. So if you can scan this QR code or you can visit these sites directly, we really hope that you would take some time to contribute to these surveys. It will help with the body of knowledge of how a pandemic, hopefully we won't be living with this much longer, but we think that we will be, are affecting everything from services to the medical conditions and so on. So please participate in those. And we really want to reinforce that as a foundation, we're here for you. In addition to really advancing and accelerating research, we are committed to you as families and helping you on your journey. I say that to both families who have been with us for years and years and years along this journey, as well as our newest families. Today was not about Rett 101. We have all kinds of materials to help you along on your journey. Today is the purpose of getting a kind of updates of where we're at, but for our new families, please connect with us and know that we're here personally to help you support and navigate all of the stages from diagnosis to the onset of symptoms, the progression of the disorder, you know, to reinforce to you and your local team that this is not a degenerative disorder, that there is a lot of hope. There is a lot that your family can do and dreams that you can continue with your child. With our support, we have state reps, Julie Peta and Maureen Carmela, who I think are on this webcast and have made themselves available to you. We also have many, many, many recordings, the handbook, newsletters, social feeds, family forums, referrals. We're here for you at every stage. At the start of the COVID-19 pandemic, when we were, as a country, went into shelter in place, we did a lot of live Facebook feeds of, with our global experts of therapists directly into families' homes to show families how they can have continuity in therapy when we were at home with equipment maybe that, you know, we were used to accessing at clinics and in school, and we were at home. You know what? These videos are recorded and they're available on our website and really are still relevant to all of us. So we encourage you to visit our website and look at some of those resources that we produced in the spring and over the summer and continue to be available to you to help you on your journey. Okay, we also have monthly Rett Ed webcasts. We have one coming up in December. Visions, cortical visual impairment is something that we're very familiar about talking about with CDKL5, which is now known as CDD, but it hasn't been talked about much in Rett syndrome, and we'll be talking about this on December 8th, especially for many of our kids who are using communication devices. You might want to get oriented about some of this new information that we're learning about impact of CVI syndrome. And in January 12, we're bringing you a part 2. As I said, our organization is working very closely with our medical experts to develop guidelines, and pain in our nonverbal children is of deep concern. It's not something that's pervasive in Rett syndrome, but when our children seem to be off or they are experiencing pain, it's really hard because they can't tell us where it hurts. So we're trying to really get some experts focused.
I hope you read that comment in their voice.
What's that?
Brian, you were unmuted for a second.
I was unmuted talking to myself.
Okay.
I go.
Sorry. Well, great. Well, chime in here if you'd like. Okay, so join us for our future Rett Eds and take advantage of the guiding care guidelines and pamphlets that we have on our website. The biggest thing that we accelerated into publication over the summer were the communication guidelines, and this was your research investment coming to fruition to help you today. It's a 116-page guide that gives guiding principles on optimizing engagement, how to do a communication assessment, how to do an AAC assessment for a system or device. All of the clinics are using these communication guidelines, and they're embedded in their practical care. But we know that many of you can't get your communication support directly through a Rett clinic, that you're getting it through your school, your care home, or you're trying to advance for communication in your own home. This is a really practical guideline and is the culmination of 6 years of research internationally around the world. So you can access that on our website. I want to give a shout out to our state volunteer representatives, Julie Peden and Maureen, who are longtime advocates of families with Rett syndrome. They are both parents and they're available to you. And Julie, we know that you are a visitor at CHOP right now, so we give you best wishes and good thoughts, and we know that you're in good hands, and we hope that things get better for you soon. Julie did want to share that there are some wonderful resources in the Philadelphia area, especially you can take a look at varietypittsburgh.org as an organization that might help you get an adapted stroller or bike for your child, which might be an organization you want to look at as we get near to the holidays. Okay, so thanks for letting me give just very, very high level some overviews of some things that we're bringing to you from rettsyndrome.org to help you on your journey. What we'd love to do now, we have quite a few questions that were submitted at the time of registration, and we have some questions that have come in into the question queue. If I can, I'm going to stop sharing my screen now and invite our presenters to come back on webcam. And we're going to go to the question queue. Let's see, we've got about 10 minutes left formally. So if you all are dialing in from work or you need to go back to your life, reminder that this is being recorded. And you'll be able to access the recording tomorrow. You'll email everyone. If you need to get back to work, go ahead and drop off, and we'll get through all of the questions. We'll take them offline and develop a QA. All right, I'm hearing an echo. I'm sorry. I'm going to turn off my webcam. Yeah, sometimes. Yeah. Well, nope. Okay. Well. My question will be.
The echo might be if we're not all muted.
Okay. You want to try muting yourselves? Love technology. It's incredible. But sorry, we're not a formal news agency. I don't have all the bells and whistles to manage this. So I appreciate all your tech support. We've all become technologists, right? On top of being Rettologists. Okay, so again, we're recording if you missed that, we're recording this. You can tune back in if you have to get back to work or school or life. And we appreciate you staying on. If you'd like, Dr. Marsh, I'm going to let you be the one to say we need to cut if you all have to get back to work, and we'll take the question queue into QA, but if you can stay on, that'd be great. Okay, so the first question that I'd like to ask, and this is always the first question in the room, is what is our current outlook for a cure or effective therapies?
So I'll take that one to start. And, you know, it's an excellent question. And, you know, to start with the effective therapies, I think there's really a lot of hope in the development of effective therapies. As we learn more and more about what MECP2 does and what pathways it's involved in and where in the brain and what aspects of brain function are altered, we can, pharmaceutical companies, academic places are thinking about drugs and ways to improve symptoms. And the trofinetide, the ketamine, and a number of other studies that are going to be coming down the pike are all towards that end. So I have real hope, and I think, you know, many people have real hope for effective therapies that improve the quality of life in people with Rett. The cure aspect is a challenging question, and, you know, medical technologies, scientific technologies that have emerged over the last decade, including the, you know, advances in computing technologies, are opening up doors that we never would have thought possible. You know, when I started in residency just, you know, like 2 years ago, can add a 0 to that, there, you know, was the thought that there's nothing you could do for kids with neurodevelopmental disorders like Rett syndrome. And, you know, we have now known that that is not the case and that there's a lot to do. You know, how effective the current batch of therapies are going to be, we'll have to see, but we should move forward with these trials. And, you know, I really do have hope that some of these are going to be very effective. And if this first swing at the pitch isn't a home run and give a cure, there'll be a second, a third, a fourth, and a fifth swing for the fence. So I do have hope, but, you know, right now, immediately, I think there will be therapeutic advances that will help the quality of life of girls in Rett. And, you know, the gene therapy and all the other therapies that are coming down, you know, as Paige mentioned briefly, you know, X reinactivation and CRISPR, and there's a lot of words that are being thrown out there that we're learning about. And so there's a lot of hope out there.
Great, thank you, Dr. Marsh. And there is a lot of hope. It's going to take us time, and we are completely committed to attacking it at all angles, right? Both symptomatically and ultimately the home run of a cure, if possible. We do have a question if the clinical trials are currently focusing on reversing Rett, or are they mostly treating symptoms?
Brian or Sam, or I can. So the two trials that we're doing now are symptom treatment and their overall improvement of quality of life treatments. So they're not reversing the disease at this point, but improving symptoms.
Okay, and we wish good luck to the companies that are bringing more advanced therapies. We have a parent of an older child who's asking if there are any trials right now for those who are 18 years old.
So as of now, the one child we have that for an 18-year-old would be the trofinetide placebo group. So that would be ages 5 to 20 years old. So as long as a child is enrolled before their 20th birthday, then you're eligible for the trofinetide trial, should you meet all the other inclusion/exclusion criteria that would be gone through during the screening process. But as of now, that would be the only one that we would have to offer.
Okay, and then at the other, thank you very much, Brian. And then at the other end, we have a parent asking what trials are recommended for a child who is 4 or 5 years old on the younger end of the spectrum. Are there opportunities?
So again, I can take this one. So for now, the two trials that we have right now, there's really no trials for any children under the age of 5. Our youngest age that we do right now would be 5 years old, and that would be for the also for the trofinetide trial, so the novel compound, to see if we give you trofinetide versus placebo, if we can improve your overall Rett syndrome and quality of life. But unfortunately for our children under the age of 5, there just currently is not any research for them at this point as far as medications go.
Okay, and thank you, Brian. We have another question here, and this is really important, so I'd like everyone to kind of listen closely to Dr. Marsh's answer here, which is from a family asking, is it worth trying a drug to address symptoms, or is it better to wait for the cure?
Yeah, that is an excellent question, and I would say that it's worth trying to address symptoms, both clinically with what we know about Rett and how to treat it, and then even from the research perspective, trying novel drugs to address symptoms. We want to improve quality of life now for all of your daughters and children. And so, we would strongly suggest that you think about medications that can do that, and whether those are experimental or research-wise or not. We all hope the cure is going to be there sooner, but it's going to take patience. It's going to take time. So we strongly recommend that you don't just give up on medicines to wait for a cure, but that you treat things as they come along, and think about or learn about these clinical trials that are symptomatic in origin.
Thank you very much. And I think we've got one more research question, and then we'll come over to a lot of questions that we've had asked about some specific clinical issues. And Dr. Marsh, this one is in the queue, and it's a question about the GW CBD trial. And is that still occurring or not?
Yeah, so unfortunately, just a few weeks ago, GW pulled the trial, and they said publicly that it was the COVID and the difficulty of recruiting at the rate at which they wanted to recruit that made them pull, and then all the challenges of performing research during COVID. So unfortunately, it's not going on at this time. Hopefully they'll reconsider it in the future.
Okay, thank you. And we understand that research is it's research, and there are things that can happen along the way, and we don't want anyone to get discouraged. We have trials that will start and stop and continue, and we commit to being there every step of the way to make sure that we follow it through to completion, but we can't always control the economics or business side, which are big dollars for folks. So that's why we're spending the time today educating everybody as to what it means to enroll in a trial, to know your rights, to know what it means to participate, so that we as families can do our part and trust with the PIs, the institutes, and the drug sponsors to stay committed to us. So it does happen. We have a number of families on the line who have women older, and they want to know what their opportunities are for participating in research. And these questions came into the queue after you talked about the natural history study and after we talked about some of the surveys that are in the trial finder. Could you give a quick summary for our families of women about ways that they can participate in research that may not be trial specific?
Sure, Holly, if you want to take this one. But yeah, so the natural history study is taking women of all ages. Our biomarker studies are taking women of all ages, and we're in the midst of plans to continue the clinical natural history type study moving forward, even after the current NIH grant. And so those opportunities are there for everyone. And it's really important to have all ages represented. One of the reasons why drug companies in Rett are focusing on the early age is that we know, there is higher numbers of patients in clinics who are younger. And that doesn't mean that there's higher numbers of younger kids, but they just get more dispersed as people graduate from pediatric hospitals and centers where a lot of the research is happening. And so it's easier for the companies, and it's more cost efficient for the companies to do it at centers where there's a lot of people. So, if we find out about sites which will take on older individuals, we'll make sure we let people know, but that other clinical data collection studies and biomarker studies and outcome measure studies would be available for everybody.
Great, thank you. And none of the progress could happen without family engagement. So we appreciate all of these questions. Getting you the answers, I hope, will help you visualize a time when you can participate, and we appreciate your willingness to do so. I know it's an ironic time for us to be talking about enrolling in clinical trials when you're still questioning whether it's even safe to walk across the door into a hospital. I hope that the information today has really given you some assurances that there are safety measures in place to help keep everyone safe, but we really do need to keep making advances as we live within this pandemic. So thanks for all of the research questions. If we have any more, put them into the queue. If we don't get to them on today's webcast, we will do a QA document afterwards. But I'd like to move over to some clinical oriented questions here that came into the queue. Now, one of them was from a parent who said that they find that their daughter is napping now twice a day, up to 3 hours at a time. And is this normal, or is this something that they should come into clinic to have evaluated?
So it could be normal, but they should come into clinic to discuss it further. In this type of venue, it's hard to talk about individuals and their care. So, yes, napping could potentially be normal, but it would be something that you should talk to your pediatrician, internist, or come into our clinic, give us a call. We'll set up an appointment to figure out what's going on with sleep.
Okay, thanks, Dr. Marsh. And we have a question from a newly diagnosed family. Their child is 3 years old, and they're asking if there's a way that they can predict or that you can help them see how severe their Rett syndrome will be for their child, and what type of special therapies do you recommend getting started on right away? And what are some of the factors that might be predictors of severity, genotype, phenotype, interactions, and such?
So yeah, we can use the genetic information to give kind of a bit of a generalized overview of what that might lead us to see and how that might impact severity. But as many families know, that some girls have the same exact genetic change but can present very differently. So we know that there are a lot of other factors involved as well. So while that can give us a general guide, it's not, a slam dunk and not a crystal ball. We also know that how your daughter is doing now is also can give us valuable information as to what we might expect to continue to see going forward. So those are two great pieces of information that can help us, give the best prediction as possible with the limitations that unfortunately none of us can, predict the future. In regards to therapies, really pushing all the therapies that your daughter's currently receiving, or if she's not receiving, getting her plugged in with those types of therapies, PT, OT, speech and augmentative communication, all of those things to really help maximize her skills is really going to be the most important, and making sure to follow the medical guidelines and the clinical care guidelines that have recently been published to, to make sure she's staying healthy and maintaining her overall general health, treating and managing the things that can be treated and managed, are really going to be the most important aspects.
Yeah, thank you, Holly. And we can have this conversation much longer, much more extended. I hope all of our newly diagnosed families connect with rettsyndrome.org or make an appointment at your Rett clinic, especially at CHOP, so that we can have that conversation more in depth. If you believe in her, there are no limits. Rett syndrome is not a degenerative disorder. Getting involved with therapies early and often and intensively, and using our care guidelines to help educate everyone who's working with her will only accelerate progress. Right, so a PT may not know about the motor involvement with Rett syndrome, and once they understand that, then they can get moving on perhaps getting her to walk or go upstairs or downstairs, or wherever she is. If they understand Rett syndrome and they're willing to work with you and partner with you, we can only have great hopes for great success. So stay optimistic. Okay.
I would just add that early intervention is very important in developmental disabilities in general. Skills build on each other. Having OT, PT, speech language pathology involved early on may help give your child some of the building blocks they need to optimize their ability to learn and kind of get to the next step. You know, there's not really research to support early intervention specifically for Rett, but when we look at large populations of developmental disabilities, we know that early intervention is effective.
Hey, Paige, let's take one or two more questions, then we'll, I think people have to start getting going.
I hear you. I agree. Okay. How about this one, which is perfect. If someone could type into the chat, for every family who would now like to make an appointment at the Rett clinic. If you could put a phone number into the chat, I will also let everybody know that if they visit rettsyndrome.org and click on For Families, they can click, and then you can click on clinics and you'll find all the direct access. Okay, so we'll close with a plug there for getting you in specifically to have more of some of these more specific questions. I'd like to ask a little bit about epilepsy, if we can. So if we're going to end with just a few clinical questions, we did receive 2 or 3 about how seizures are treated in children with Rett syndrome, and what are the common types of seizures that kids have, and young, early in life, teenagers, and adults. Can you cover that in 30 seconds or less, Dr. Marsh?
Well, yes, because I could say go to the webinar that we recorded. When was that, Paige? A year ago?
Yes, sir.
Yeah, but besides that plug, so, you know, epilepsy in Rett syndrome can be complex. One of the issues is what is seizure and what is not, because Rett girls do some, and women do some very interesting movements that look like seizure, but often aren't. So the first step is, you know, knowing for sure whether something's a seizure or not. Then, you know, the types of epilepsy in Rett can be very variable. There can be convulsions, there can be staring spells, there can be drop spells, and a lot of different types of seizures. So knowing which seizures there are, and then choosing the right medicine for those types of seizures. There is no great data on if any specific medication works for Rett. We are actually in the midst of analysis of the natural history data, so looking at, you know, many years worth of data and over 800 patients to see if we can find that there's a best med for Rett. But right now there isn't. And if you know, talk to different Rett specialists around the country about what their favorite seizure med, they're going to all give you a different answer. So there is no right one, but hopefully from an analysis of the natural history data, we'll be able to, next time we have this, give a slightly different answer to that question. And then the last part of that, if older women, you know, women as they get older with Rett can continue to have seizures, and the same types of issues exist in the older women as with younger girls with seizures.
Great, thank you, Dr. Marsh, and absolutely, I encourage everyone to watch your in-depth webcast that we did on epilepsy and seizures and spells in Rett syndrome. It was really wonderful. Okay, we have three questions that I would like to touch on. One is about GI issues, one is about hyperventilating, breathing issues, and one is about autism therapies versus Rett-specific therapies. Do we have time to tackle all 3?
Sure, then we'll end on those.
Okay, all right. So regarding GI issue, the GI question is about stomach bloating in particular. I know we don't have a GI specialist on the call today, but as a Rettologist, do you have any advice?
Yeah, so one of the big problems with bloating in Rett is air swallowing, and you know, with hyperventilation or breath holding, they swallow a lot of air. So if the child has a G tube, to vent the G tube often to release as much of that air possible. You can even massage the belly to try to move the air forward. And then, you know, talk to the gastroenterologist about the certain medications like Gas X that you can use to move the air forward. And then the other thing is to make sure that bowel movements are complete, that they're not, still don't have a lot of retained stool that can give bloating as well. So those are a whole bunch of things to think about in Rett and bowel movements and bloating.
Thanks, Dr. Marsh. And that pivots to the question on breathing and hyperventilating and some of the breathing issues that we see in Rett syndrome. Do we have medications to treat and help?
Yeah, so, unfortunately, there was a clinical trial, and this, Paige mentioned sometimes they work, sometimes they don't. There was a clinical trial that was completed 6 months ago or so that did not show evidence of improving breathing in Rett. There are a number of medications that we anecdotally, from just our experience, we know that can sometimes help, and we've had success, but it's a trial and error process. So there are different types of medications that we can try for irregular breathing that we see in Rett. One of the things to note that is if it's not interfering, if they seem comfortable, not to get very upset about the breathing because it's not hurting them. And even girls who will hold their breath for a long time and turn a little blue or dusky, they always come out of it. They always start breathing again. So just remain calm, relaxed when you're in an event like that.
Thank you very much. And we do, again, we have some webcasts and we have additional materials to help. So reach out to me if any of these questions need further exploration. We can connect you with materials and information. And again, make an appointment at your Rett clinic, and everything is unique to your child. Rett syndrome doesn't necessarily define them. They have a whole lot of other things that could be going on, and we want a professional to deal with these. Okay, and the last question for you all on the panel today is for our families who maybe initially got a diagnosis of autism and now have properly landed in the world of Rett syndrome. How do you think that these families should continue with autism, particularly ABA therapies, or should they transition and rethink their course of therapies and interventions, especially with PT, OT, speech, and communication?
Todd, do you want to start to tackle that, or?
Sure. A lot of what we do as OTs, I'll definitely speak for OT, is not specific to, or not very specific to diagnosis. We find that a lot of our therapies for developmental disabilities work regardless of the specific diagnosis, because we're very much focused on tackling functional problems. We think about a functional problem, say it's bringing food to mouth, and then looking at those barriers. Those barriers, the actual barriers themselves on a practical level are more important to guide our therapy than the actual diagnosis in most cases. And so, for example, ABA therapy, very effective for autism, very effective for a lot of children with traumatic brain injury. It's really based on tried and true principles of psychology, and I would have every reason to believe why they would help you overcome behavioral barriers to success as well, or looking at behaviors that you want to extinguish, you want to get rid of. When I talked about the looking at antecedent behaviors, what's happening before self-injurious behaviors, that really comes from ABA therapy. So we're gonna, on a practical level, an OT is gonna draw on the autism literature because there is more autism literature, and I have a lot of reason to believe that those things are going to work for Rett as well. We may have to modify them. The barriers may be slightly different, but the process and the intervention is essentially going to be the same.
Okay,
Yeah.
Great.
I was just going to add, I totally agree with that completely. And, that there are, unfortunately, fortunately, because autism is more prevalent and a big issue now, that there are more opportunities in some ways through getting autism therapy. So we don't recommend, just cutting that off, but making sure that the therapists know that your daughter has a specific disorder and to think about what's known in Rett, but also engage the whole autism literature as well.
Great. Thank you. I think we have done a phenomenal job at attacking so many variety of questions that came into the queue. Thank you to everyone in our attendee list for being so engaged. We know how much your children mean to you. You have to trust and know that we at rettsyndrome.org and everybody at the CHOP Rett Clinic team are here for you. And today is not the end of this conversation. We will come together again. We will answer any questions that we didn't get to in the queue, and you can reach out to us at any time. If you look into the chat feature, you'll see the phone number where you can make an appointment at Chat and Chop. Tongue twister there. You can reach Odell Richardson at 267-426-1242. If you want to access any of the webcasts that we talked about, going in depth on breathing, sleep, epilepsy, research, clinical trials, you can find those at rettsyndrome.org/4families/education. We have an entire digital library, which is being refreshed all the time. So please take a look at those and reach out to me anytime you have some questions. We really appreciate you being with us today for a long time over lunch, and we know you're busy. We know there are a lot of things competing for your time, and we appreciate your commitment to your children. To our panelists, thank you so much for such an extended part of the middle of your day and the middle of your week. We really value all of your efforts. We thank you for serving on our work groups and our advisory boards, and most importantly, we appreciate you taking such great care of our kiddos every single day. And we wish you good luck continuing to navigate this new way of delivering healthcare. And we appreciate all the pivoting that you have done to meet us where we need to be right now. This concludes our webinar for the day. We wish you all well, and we hope to see you on December 8th to talk about cortical visual impairment and Rett syndrome. Okay, thanks everyone. Bye-bye.